Good evening, everyone. Thanks for joining us on this joint webinar with the World Federation. On behalf of the ISCCM, I am extremely grateful for the World Federation for giving us this opportunity of sharing our views and our thought processes on antimicrobial resistance. We have today three distinguished speakers who have excelled in the field of critical care for the last 25 years or more, and they will be deliberating on certain key aspects of antimicrobial resistance. To start the proceedings today, we have Dr. Subhash Todi, one of our senior most members of the Indian Society, who has been a chairperson of our research and a member of our guidelines committee, a senior teacher, and currently the lead intensivist at Manipal Hospital, Bhattacharya in Kolkata. He will be speaking to us on emerging infectious diseases and the need for broad-spectrum antibiotics. He will be followed by Dr. Pradeep Kumar Bhattacharya, our immediate past president of the Indian Society of Critical Care Medicine and the Dean of Studies at Ranchi in RIMS. And then we have Dr. Deepak Govil, who was the immediate member of the World Federation from India and the Director of Critical Care at Medanta Hospital, New Delhi, and a past president of the Indian Society of Critical Care Medicine. And he will be speaking about the role of diagnostics in guiding antibiotic use and combating resistance. So we start the proceedings with the talk by Dr. Subhash Todi, and he will be speaking to us on emerging infectious diseases and the need for broad-spectrum antibiotics. Dr. Todi.
Thank you. Thank you, Srinivas. Let me just share my slide. Can you see my slide, Srinivas?
Yes, sir.
Yes,
they are visible, sir. Please go ahead.
So thank you, and thanks World Federation for inviting us. And I think it will be very good joint effort. So this is the topic given to me, and we all know that this week is the Antimicrobial Resistance Awareness Week. So I think it's very pertinent to talk about this increasing resistance pattern and emerging infectious diseases. This is the list of resistance infection which have been highlighted by WHO and endorsed by our Department of Health. The most important are the carba-resistant Enterobacteriaceae, E. coli, Klebsiella, which are also getting resistant to colistin. The second are the Acinetobacter and Pseudomonas, the non-fermenting bacteria, again resistant to carbapenem. I'll be restricting my talk because of the time constraint on gram-negative bacteria, but we should be aware that there are resistance increasing in gram-positives as well, Staph aureus and Enterococci, and also in Salmonella and also in fungal infections. So it's very important that we keep this in mind. So just to give you an overview of epidemiology of resistance that we are facing in India, this is taken from our Council of Medical Research and GLASS, which is a WHO-endorsed surveillance system. One is E. coli resistance to carbapenem. E. coli resistant to carbapenem is 20%. Klebsiella resistant to carbapenem is around 57%. Pseudomonas, thankfully, is less resistant to carbapenem, but Acinetobacter is a most important beast. It is resistant to carbapenem in 78% in our country. So we are looking at very high degree of carba-resistant in most of the Enterobacteriaceae and non-fermenters. Polymyxins, thankfully, we don't have yet a very high resistance as opposed to in some other parts of the world. Polymyxin resistance is only 2%. So this was the phenotypic resistance. Now we have different genotypes. The Ambler classification, as you all know, is A, B, C, D, of which the big five worldwide are NDM, OXA, KPC, VIM, and IM. And in India, we mainly face in Enterobacteriaceae, NDM, OXA, or a combined. And not many places have a facility to do genotypes, but one can interpret genotype by looking at the phenotype. So this is the background. Now, given this increasing carbapenem resistance, I think our first strategies will be how can we spare carbapenems? You see, this was the first trial, Merino trial between piptase versus Mero in ESBL, that is ceftriaxone-resistant bacteremia, which found that meropenem saves life. And that was the reason that Mero was started being used more and more than piperacillin tazobactam. And it was found out that many of the bacteria which carry ESBL also have OXA1-like enzyme. So that becomes a big problem. So we require a newer antibiotic which will be better than piptase and will work in place of carbapenem in ESBL. So cefepime N-metazobactam, it was brainchild of one of the Indian pharmaceuticals. It was the first approved cefepime beta-lactamase inhibitor for MDR enterobacteriaceae. A head-to-head trial with piperacillin tazobactam and with cefepime N-metazobactam has found that this is definitely better than piperacillin tazobactam. So unfortunately, there has not been much head-to-head trial of this along with meropenem, but it's definitely better than piperacillin tazobactam. So we can have at least some carbas sparing strategy by using this BL-BLI combination. So as you can see, this covers cefepime N-metazobactam, will cover KPC, which is not very common in our country. They say it covers, it doesn't cover KPC, it covers ESBL, AMC, and OXA48. And this is what we are after. We are mainly after coverage of ESBL, so which is very good coverage for cefepime N-metazobactam. Then comes this newer aminoglycoside, plazomicin. You know, this was once daily plazomicin for complicated UTI, where it was compared with meropenem. The bugs may be resistant to the conventional aminoglycoside, but plazomicin was found to be better. Another advantage of plazomicin is many of the enterobacteriaceae in our country have penicillin binding protein 2 mutation, which makes them resistant to even the newer generation cephalosporins and BL-BLI. And that is where the plazomicin might work. So this is another drug which can be used in place of meropenem in patients with a reasonable renal function. So that was the carba sparing strategy. So now what about having infection with carba resistant organisms? So the only workhorse that we have till now was colistin. So ceftazidime avibactam we have been using in India for a long time. Since this is the World Federation webinar, this has recently been launched into Bangladesh, Nepal, Sri Lanka, and these other parts of the world. And ceftazidime avibactam, as you can see, covers OXA48 apart from ESBL. So it's a very good drug. It doesn't cover NDM. KPC is not very common in our country. So ceftazidime avibactam will be a good drug to use if you have carba resistant, but non-NDM, where it is ceftaz-avi sensitive. So now if we have an infection with New Delhi metallo-beta-lactamase, which are ceftaz-avi resistant, and say if you have a pneumonia, a lobar pneumonia with Klebsiella with ceftaz-avi resistance, how do we go about it? You know, aztreonam is an antibiotic which works against NDM, but it is hydrolyzed by ESBL. Most of the bacteria which contains NDM also contain ESBL. So we can't give it aztreonam. Whereas avibactam is beta-lactamase, so that will kill the ESBL. So aztreonam will work. So this test, what we have been calling synergy test, where both ceftaz-avi and aztreonam are resistant, but if we use them together, it works. So this is what we have been using. In India, Klebsiella are usually synergy positive. In E. coli, 70% are synergy positive. So we can get away with NDM E. coli and Klebsiella by this. But the problem with ceftazidime, avibactam, aztreonam, as you could see, it covers oxa, KPC, and NDM. But the problem is, there are two different drugs which have to be given at the same time with two different infusion. And truly, we don't require the ceftazidime. We require the aztreonam and avibactam. And there are PK/PD issues. And that's why this aztreonam avibactam has been launched recently. It has been launched in India recently. As you can see in the top, it covers almost all. It doesn't, including NDM. It doesn't cover Acinetobacter. So aztreonam avibactam, just like ceftazidime with aztreonam, without ceftazidime, will be very important. It covers oxa, it covers ESBL, it also covers NDM. Doesn't cover Acinetobacter. And it has been approved for bloodstream infection, for VAB, HAP, and intra-abdominal infections. Another very good broad spectrum antibiotics, FEPIMCTI. As you can see, most of them are green, except the Acinetobacter doesn't cover Acinetobacter, though it is red in MBL, but there are studies which have shown that it does cover MBL as well. So ceftazidime avibactam will be another BLBLI, another product of one of the Indian pharmaceutical, which have been not yet marketed, but will be a very welcome BLBLI in our country. Another BLBLI, cefepime-taniborbactam. This has been compared with meropenem and has been found to be a very good drug as compared to meropenem. But even it works in carba-resistant organisms. So we have to keep that in mind. So it works with ESBL, works with NDM, works with oxa, doesn't work with Acinetobacter. So it looks like Acinetobacter is a beast that we need to conquer. So coming to Acinetobacter, presently we have this sulbactam, minocycline, tigecycline, phosphocolistin as our workhorse. But we require better drug. Sulbactam, minocycline are not that potent by itself. So sulbactam durlobactam is one of the most potent anti-Acinetobacter drug. The way it works is, sulbactam is a very peculiar antibiotic which works against Acinetobacter because it binds to penicillin binding protein 2, which most of the other antibiotics do not. But the problem with sulbactam is it is killed by ESBL enzymes in the periplasmic space. So combining durlobactam along with sulbactam, durlobactam is a beta-lactamase inhibitor, will take care of most of these ESBL enzymes and will let sulbactam work. So this has become a very important drug, and this has been published, and with a non-inferiority of sulbactam, durlobactam versus colistin against Acinetobacter, and with much less toxicity. So it will be a very useful drug in future. Eravacycline is another newer antibiotic, which is a group of tetracycline, but has a better affinity than earlier generation tetracycline, and it does have activity against Acinetobacter. So eravacycline works against Acinetobacter. So these are the compounds that can be used against Acinetobacter. Then comes the broadest spectrum antibiotics that we have for the currently emerging infectious disease. It is available in the West, like on Fetroja, which is a Trojan horse. As you can see, it enters into the cell under the guise of iron. And that's where then it gets dissociated from the iron and then kills. Because the normal antibiotic uses porine channels. It doesn't use porine channel. It uses iron channel. So it is a siderophore antibiotic, siderophore cephalosporin, cefiderocol. And by this peculiar mechanism, it enters. And this is one of the broadest spectrum antibiotics that we have in the market now. And there are trials. There are few trials which have not that effective against Acinetobacter, but that has been questioned. As you can see, cefoterocol has a very broad spectrum of uh, antibiotic spectrum. It covers almost everything, including Acinetobacter. So I think this is again a very welcome move. So as you can see, we have a plethora of BLBLIs. Most of them have gone through phase 3 studies and have already been launched into the market. Somebody are awaiting to be launched. So hopefully in the future, but bacteria are smarter than what we are. And again, I'm sure they will be resistant to many of these BLBLIs, and we need to keep on working on how to have antibiotics which are long-standing sustainability, and that can only be used by judicious use of these antibiotics. Thanks. Thanks for your patient listening. Over to you, Srinivas.
Thank you, sir. I think that was a very crisp and comprehensive review about what drug resistance is all about, what we are facing, what solutions we can have and expect in future, but also a note of caution that the pipeline is running dry and we need to be more vigilant. We go on to the next talk of the evening, and that's about a two-pronged approach to antimicrobial therapy in the era of resistance. And that will be dealt by Dr. Pradeep Bhattacharya, our immediate past president, Dean of Studies at the Rajendra Institute of Medical Sciences, Karachi. Sir.
Thank you. Am I audible?
Yes, sir. You're audible. Please share your slides.
I'm not able to project my slides. Somehow it is not coming. I don't know. Shall I send it to you, Srinivas, by WhatsApp?
Yes, sir.
हाँ शेयर आ रहा है लेकिन वो स्लाइड हमारी दिख नहीं रही है. मैंने ओपन किया हुआ है. डॉक्यूमेंट्स में ही जाना ना. स्क्रीन्स पे गया लेकिन
होल स्क्रीन
खुली है लेकिन पावर पॉइंट आ नहीं रहा ना. तो जस्ट 1 मिनट है. ओके. ये इसमें है ना. बड़ा तो कर लिया लेकिन इसमें वो शेयर पे गया. वो एक्सक्लेमेटरी साइन दिखा रहा है. नहीं कर रहा था वही कर रहा हूँ लेकिन पता नहीं समहाउ ये एक्सक्लेमेटरी साइन दिखा रहा है.
So send it to me, sir. I will do it. In the meantime, we'll take the other talk.
हाँ ये आई थिंक डॉक्टर दीपक कैन प्रेजेंट स्टार्ट. मैं आप तुम्हें भेज रहा हूँ श्रीनिवास. देयर इज सम प्रॉब्लम.
Yeah. So we will.
Yeah. I think
Yes,
you
sir.
start.
We'll go to the other talk of the evening, that is the role of diagnostics in guiding antibiotic use and combating resistance. And we will now go over to Dr. Deepak Govil, also a immediate past president of the Indian Society and was a member of the outgoing World Council of Intensive Care.
not treating that sepsis as fast as we should? Are we not treating sepsis with a broad spectrum antibiotic? As we all know, for every 1 hour delay in effective antibiotics for septic shock, the survival decreases by 7.6%. And this reality mandates a prompt broad spectrum empiric therapy. But again, on the other side, there is a diagnostic dilemma as well. If I start these high end or broad spectrum antibiotic unnecessarily, what will happen? So, every day of unnecessary broad spectrum antibiotic exposure increases the risk of antimicrobial resistance. It increases the organ toxicity, could be acute kidney injury. Many drugs are having some effect on the kidney. Then they could lead to the secondary infections like Clostridium difficile infection. Like if we are using too much of the antibiotic, many times the opportunistic microbial organism they come up, and sometimes even we can these multiple antibiotics can cause the growth of the candida as well. So in that mandate, we have got de-escalate and be narrow. So on the one side, we have mandate to de-escalate and be narrow, and on the other side, we have mandate to treat fast and treat broad spectrum antibiotic. So we have to make a balance in between that, and that balance is most of the challenging. If I talk about the global burden of antimicrobial resistance, there are 1.27 million deaths, direct deaths due to bacterial resistance. And this was the 5 years old data, and now the number is more high. So we are in the era of a silent pandemic where the global burden of antimicrobial resistance is staggering, exceeding the annual deaths from HIV, AIDS, or malaria like tropical fevers. In ICU, with its high antibiotic pressure and vulnerable patient population, serves as a critical epicenter for the emergence and spread of multi-drug resistant organisms. That is well-known fact, nothing new. We have the shift in the treatment strategy. On one side, we have got empiric approach where we know we have to hit fast, hit hard, prescribing broad spectrum antibiotic based on the clinical symptom alone. That is the best guess, or depending on the local flora and the antimicrobial resistant pattern. This risk often is unnecessary, ineffective, and too broad. And this may be a key driver for resistance. Another end, there is a diagnostic guided approach where we use a specific test to identify pathogen and its susceptibility. It gives leverage in enables us to enable target appropriately and effective design in effective therapy. And of course, it preserves antibiotic efficacy because we are using targeted antibiotic rather than a broad spectrum antibiotic. So, if we talk about the antibiotic stewardship, there are 5 rights: right drug, right patient, right dose, right route, and right duration. And it can cause increase in the cure rate, decrease in the treatment failure, decrease in the opportunistic infection like C. difficile infection, decrease in the adverse drug events, decrease in the resistance, decrease cost, and decrease length of stay. But now it is the time to add another dimension to it, that is the right diagnosis. So once we made a right diagnosis, all these 5 points automatically becomes right, and then we have to juggle with very little in this puzzle of antimicrobial stewardship. So, if we talk about the evolution of the diagnostic, we all know about the traditional cultures. We all send pair two cultures, one from central line, maybe one from peripheral line, or maybe two from two center peripheral lines. They are the gold standard. From years together, we are sending them. They are slow, but they are comprehensive. But the problem is it takes time. The earliest tick could be in 24 hours to 74 hours. And till then, we are just giving broad spectrum antibiotics. And you can say that we are just fighting in a blind. Then comes the rapid molecular test. These rapid molecular test uses the polymerase chain reaction. It detects the DNA and the resistance genes. And the result can come in 1 to 3 hours. Then there are point of care tests. which are having time of less than 30 minutes. Sorry. They detect genetic materials, they detect the proteins, they detect antibiotics, antibodies, and on that basis, they give the result. But again, they lack sensitivity and sometimes they lack specificity as well. Then comes the biomarkers like CRP, PCT. We all do that. But again, the TAT is 2 to 6 hours and they are very vague. They did not give us idea which organism are we dealing. They just give us idea that something wrong is there, some host response is there in the due to some infection. Then advanced phenotyping is there. The TAT is 4 to 18 hours, like MALDI-TOF, like automated antibiotic sensitivity testing system, VITEC, they are there. And they are emerging gradually, they are becoming more and more popular. So in this slide, I am just summarizing the rapid pathogen identification test. In short, we can call them RDTS, rapid pathogen test. And mainly they are PNA fish, like morphokinetic cellular analysis, then PCR plus microarray, PCR plus microarray. So different companies are having different brand names and different type of the technology. So acylate pheno is the PNA fish, the Verigene is the PCR plus microarray, COBS is the PCR plus microarray, BioFire film array is the PCR plus microarray, rapid MBT sepsi-typer is MALDI-TOF plus MS. The T2 bacteria panel is miniaturized magnetic resonance. The Carius is the metagenomics, and the Discover again is a metagenomics. So different target organisms are there. Gram stain dependent, they are not gram stain dependent. They are few are having the sample as a blood culture and few are having the sample as a whole blood. Like miniaturized magnetic resonance, here we can use the whole blood. In metagenomics, we can use whole blood. Whereas in the PCR, MALDI-TOF, PNA fish, if once the growth is there, then we can use that. And these are the. So what is the impact of these rapid diagnostic tests plus stewardship? So there are multiple studies which are consistently showing that the combining rapid diagnostic test with the active antimicrobial stewardship significantly shortens the time to optimal therapy and de-escalation of inappropriate antimicrobial empiric therapy. And the faster time to optimal therapy is come down to around 29 hours. If we look at the culture base, then it becomes most of the time it becomes of 48 to 72 hours. So host response biomarkers are there. They aids in the diagnosis. There is a risk stratification and follow the trend. So we can rule out the non-infectious causes like trauma, surgery, burns. They can elevate these biomarkers. Immunosuppressed patient may not mount a strong biomarker response. So these host response biomarker like procalcitonin and CRP, they sometimes aid in the diagnosis and risk stratification and follow trend, but they fail on a patient who is a trauma, surgery, burns, where the biomarkers are elevated, or immunosuppressed patient where the strong biomarker response is not mounted because of the immunosuppression. And localized infection like abscess, this may not trigger a high systemic response. If we talk about the procalcitonin guided de-escalation, I would like to highlight few studies here, like ProRata study, which was published in 2010. They showed 23% reduction in antibiotic exposure with non-inferior mortality. SEPS 2016 study, in which they have showed that procalcitonin guidance reduced duration of the treatment by an average 1.2 days and was associated with 5.4% reduction in 28-day mortality. There were meta-analyses published in 2018, 23, and 24, which again highlighted that procalcitonin guided discontinuation strategy shortened antibiotic treatment duration by an average of 1.8 to 1.9 days and were associated with mortality benefit. Then ADAPT sepsis study published in 2024, where care guided by measurement of the procalcitonin reduces antibiotic duration safely. So if we talk about the summary, standard care, no procalcitonin, usually the average duration in these studies are 8.2 days, and with procalcitonin guided discontinuation is around 4.5 days. That is the average duration. Side by side, we have to think about the diagnostic stewardship as well, because there are too many tests. I have shown you multiple tests. There are too many tests. They are not very standardized. Few of them are not very sensitive, and few of them pick up colonizers as well. So sometimes it becomes difficult to identify which bug we are dealing with, and of course the cost is also involved. So, a coordinated approach to improve selection, performance, and interpretation of diagnostic tests that inform antibiotic management should be done. And diagnostic stewardship is a complement to antimicrobial stewardship. So, if I talk about the diagnostic pathway where to intervene, in a pre analytical stage, we have to understand the appropriate testing and guide the team for good collection, the safe collection or appropriate collection. Alerts for inappropriate order collection should be there. We should have collection protocols, and there should be pre-test probability that this test will give what is my idea to identify pathogen, and which test is appropriate for that pathogen. And not only the pathogen, the site of infection is also important. Then comes the analytical part of these diagnostics. It should be the accurate and rapid result, and rapid diagnostic, selective reporting by the lab. I'll discuss with this selective reporting in the successive slides. Then in post-analytical phase, we have to look for appropriate interpretation and the action. Many times it happens the result is there, but in the night time, if the senior person is not there or they are too busy, then somebody is not interpreting the result and the appropriate action is not taken. So we have to do that also. And then we have to consider the microbiology nudging on the reports and antimicrobial stewardship driven feedback. We'll discuss this in successive slides as well. So the CDC says that they have given this guidelines as a premier for antibiotic stewardship program, the how to identify this. So microlab may not perform this sensitivity test for a particular bug drug combination. So if microbiology lab knows that this bug drug combination doesn't work, this drug doesn't work for this bug, so it is not giving any sensitivity, antibiotic sensitivity, antimicrobial sensitivity for that drug. As we have already seen in last slides, that all the antibiotics are not working on all the bugs. So if we know that this drug is not working on Acinetobacter, then why to give sensitivity? Suspected contaminants or usual flora. So if there is a suspected contaminants or usual flora, the sensitivity will not be given. Susceptibility resistance can be predicted by organism identification alone or based on the results of other drug tests tested, and may not have interoperative breakpoints. So here in this situation, the lab will not give the bug drug combination, the test, sensitivity test. Selective reporting, the bug drug combination inappropriate for a given site of infection. Then there is no fun reporting that. That lab can omit that. Otherwise, we'll start giving unnecessary antibiotic. Drug inappropriate for particular patient population like elderly population, pediatric population, patients with having kidney diseases, liver diseases. Some drugs are not appropriate. So why to give report sensitivity for those drugs, susceptibility test for those drugs? Suboptimal outcome with a particular drug in the treatment of a specific resistance phenotype or serious infection. As we all know that many bacteria nowadays are producing ESBLs and they are MBL. So if we know that this particular drug is not working on the MBL, then why to give susceptibility to that result? Otherwise, somebody can misjudge that, misread or misjudge that report and can start those antibiotics. Then there is a cascade reporting. Results for secondary agents are reported only if the organisms are resistant to primary agents. So there are certain reserve drug or secondary drug, alternative drugs, alternative antibiotics for particular bug, which are having probably more side effects or the less efficacy. So we should restrain, the lab should restrain giving giving antimicrobial susceptibility test for that drug, unless the primary agents like the main horse like carbapenem or the piperacillin tazobactam or any other drug which is the main horse of the day-to-day therapy is resistant. So IDSA given this practice guidelines, although majority of them are weak recommendation, should antimicrobial stewardship program work with the microbiology laboratory to perform selective or cascade reporting of antibiotic susceptibility test results? The recommendation is they suggest selective and cascade reporting of antibiotics over reporting of all tested antibiotics. It's again a weak recommendation, low quality of evidence. Another guideline, should antimicrobial stewardship program advocate for use of rapid viral testing for respiratory pathogens to reduce the use of inappropriate antibiotic, because in most of the labs we are not doing routine respiratory pathogen viral testing, and at the end of the day those patients who are having viral respiratory infection we end up giving the antibiotics. So the recommendation is the use of rapid viral testing for respiratory pathogens should be there to reduce the use of inappropriate antibiotic. Again, the weak recommendation and low quality evidence is there. Another recommendation is, should antimicrobial stewardship advocate for rapid diagnostic testing on blood specimens to optimize antibiotic therapy and improve clinical outcome? The recommendation is rapid diagnostic testing in addition to conventional culture and routine reporting on blood specimens, if combined with active antimicrobial stewardship program support and interpretation, should be there. And it is a weak recommendation, but moderate quality evidence is there. And the comment is, availability of rapid diagnostic test is expected to increase. Thus, antibiotic stewardship program must develop process and intervention to assist clinician in interpreting and responding to the appropriately to the results. So how we can see an integrated stewardship workflow? It includes both antibiotic stewardship program as well as the diagnostic stewardship program in relation to the infections. On the 0 hour, when a patient is coming to the septic shock, draw cultures, send procalcitonin, send this rapid diagnostic test as well, and start empiric antibiotic. Within 2 hours, you will get the result of this rapid diagnostic test. Like, for example, I am saying here, if we get the result of the E. coli with MBLCT-XM is there and PCT is 12.5, we de-escalate to the targeted agent. So antibiotic is de-escalated right after 2 hours. So first dose was given as a broad spectrum and the successive dose was de-escalated to the targeted agent, as we all know by this rapid diagnostic test that what we are dealing with. Within 48 hours, patient improving, continued the targeted therapy. After 5 days, we look at the procalcitonin, trend is coming down, it has 0.2. At this time, we can feel appropriate to the antibiotic as per protocol or clinical recovery. So to conclude, rapid diagnostic test and biomarker are not a replacement for clinical judgment, but are powerful tool that when integrated into stewardship programs, enable faster, safer, and more precise care. Thank you very much.
Thank you, sir. We will now try to go to Dr. Bhattacharya again, and for the dual-pronged approach, we will try to get the presentation going again. Sir, Pradeep, sir, can you please switch on your camera? Pradeep, sir?
Yes, I'm here. Dr. Srinivas, please project my slides.
Okay.
So my job is in next 15 minutes or so is to tell you about the two-pronged approach. And I must thank World Federation for giving me this opportunity and Dr. Srinivas our president, for giving me this opportunity.
Are the slides visible, sir?
No, it's not
Are
visible.
the slides visible?
No, it is not visible, Srinivas.
Still not.
Now,
Yes.
is it okay now?
Now it is visible. Just make it a
Yeah,
full screen. Okay. So can you make it full screen, Srinivas?
It is in presenters mode actually. You have to go to slide share, show and remove the presenter mode. उधर से ही कर दीजिए, from beginning कर दीजिए. First one को कर दीजिए.
Is it coming now?
No.
No.
Just 1 minute.
Doctor, no worries. You can present. Okay. 1 moment.
Is it okay now?
No, I think no, but I am starting. Okay. Anyway, I think it is visible.
Yeah,
to
just
all.
in that way, doctor. No worries.
No, okay, fine. So I have no conflict of interest. Follow first of all. Next, please go to the next slide. Srinivas, can you hear me? Yes. So first of all, let us see what World Health Organization says about this resistance part. Is that the resistance level have increased to more than 40% of monitored pathogen. And from 2018 to 2023, almost there is an yearly increase of 5 to 15%. And in 2021, there is a data that almost 1.27 million deaths have happened worldwide. And they say it is mainly affecting the vulnerable population in the middle and low income countries. So Southeast Asia is one of them, and others are like African countries. But they say that if this trend continues, then almost 39 million deaths will happen from 2025 to 2050. And that is an alarming sign. Next slide, please. And sepsis, we all know that almost it affects 50 million people, and that accounts to almost 20% of all global deaths. And because of antimicrobial resistance, what happens? It fuels into development of septic shock and multi-organ failure, and finally death. And it is 20% when we talk global, but when it comes to low and medium income countries and Africa, it is almost 30%. So mortality goes up to 30% in these low income countries. So next slide, please. So why is this nomenclature, two-pronged approach, has been used basically to develop a precise and effective treatment and to implement responsible antibiotic stewardship. Previous two speakers have already spoken on some of the important things. I think my job will become easier because many things you have heard from previous speakers. So mechanism of antibiotic resistance, already all of you know, and this is just an example slide to show that all those mechanisms through which a bacteria develops resistance while they are in the body and while they are given some kind of antibiotic. Next slide, please. And when we talk about this two-prong approach, as I said, first is we try to uh, attack the organism in a precision manner, and on the other side, you try to do stewardship. But final ambition is to give an integrated decision point where we think that we're able to kill the bacteria. Next, please. Next one. Next one. This is hidden slide. Next one, please. So when we talk about this precise and effective treatment, what are the points we try to cover? Just now, Dr. Deepak Govil was talking about rapid diagnostics, but PKPD is another important thing. Source control and synergistic, that is a combination therapy. When we talk about stewardship, we talk about de-escalation, duration shortening, restrictive guidelines, and non-antibiotic interventions. And all of these, they require actually a multidisciplinary approach. So first of all, let us go to prong one. Next slide, please. So in prong one, we see, as I said, PKPD is one of the most important thing in critical illness. Therapeutic drug monitoring is another important thing. Then dosing optimization, source control, rapid diagnostic, then synergism and combination of antibiotic, de-escalation, duration. And all these points I'll discuss, which are important. So what happens in pathophysiological issues with critical illnesses? It augments renal clearance. So ARC, we know it is a very common phenomenon and it's a proven phenomenon nowadays. So what it does, it creates a subtherapeutic antibiotic level. Expanded volume of distribution, again, that affects antibiotic concentration. Hypoalbuminemia has a direct effect on the binding issues. Organ dysfunction impairs metabolism. Extracorporeal therapies, when we institute, it has got additional problems. Next slide, please. So when we talk about this two ways, one is a hyperdynamic state and another is end organ dysfunction. On the one hand, there is a decreased plasma concentration, and on the other hand, there is an increased plasma concentration. So our job in two-prong approach basically is to balance between these two, that is the plasma concentration. And so on the one hand, this optimization is achieved by administering high initial doses, using prolonged beta-lactam infusions, stewardship to optimize the drug exposure and reduce clearance. And the most important, which has come in 2025, is that therapeutic drug monitoring and a real-time TDM combined with patient covariates. That is important. The next one is source control. You see, these are 2025 reviews, and they say that if we do a proper source control of bloodstream infection, this was a study which was published in 2025, they say within 24 to 72 hours control that improves survival by 65%. Then there is Japanese Society update also says that a continuous source control within sepsis chain of survival framework with and multidisciplinary approach can also improve survival. Then another narrative review that came in updates of surgery, and that suggests that an urgent, if you do necrotizing soft tissue infections, urgent debridement and high dose and prolonged beta-lactam infusions we give, and the things that there is a 10 to 30% mortality reduction, and if we target these things within 48 to 72 hours. Next one, please. Now, then comes the rapid diagnostics. We just now listened from Dr. Deepak Govil about the rapid diagnostic testings, and one of the reviews that came in 2025 that says covering 6 technological categories and point of care approaches, of which the most important are CRP, interleukin 6, procalcitonin, have got a high magnitude, and they create, if you do it, the survival rate of the patient and antibiotic selection becomes easier. And also, their impact underscores that maximized when embedded with a structured antibiotic stewardship program. So both combination has got a very beautiful impact on the outcome. So these again, the another important thing is antibiotic synergy. That is a combination of antibiotic, empiric combination of antibiotic therapy. And this is one of the publication which came in Nature Review. And that suggested that although there are guidelines from the institute, from the state, and from the national level, but they say the best way to do this thing is that tailored based on your local epidemiological antibiotic stewardship program rather than following those formulas. Then IDSA has also given a combination therapy for gram-negative, and this is 2024 guidelines. And they have recommended the use of ceftazidime, avibactam plus aztreonam for MBL producing CRE. And another combination recommendation is for crab organisms, that is sulbactam, durlobactam. Just now, Dr. Todi was telling about that, or meropenem and imipenem with cilastatin. And alternatively, they said the combination, a high dose of ampicillin sulbactam at least one agent with polymyxin or minocycline if sulbactam, durlobactam is not available. Then another important is the first line monotherapy, which is susceptible but ineffective if the patient is immunocompromised. In those cases also you can do that. De-escalation, we heard a lot of about it, but a multiple approach by using procalcitonin, that is one way. But if we apply machine learning to this de-escalation process, what Adapt Sepsis trial has said, and then followed by addition of machine learning, that further reduces 8% reduction in mortality. And the extended duration of beyond clinical resolution, that means a long duration of antibiotic therapy does not show any benefit in mortality. Rather, a specific and short duration has got a better outcome as far as adverse effects are concerned. And this 2025 guidelines also suggest the same thing. Then comes the second prong, that is the stewardship and antibiotic conservation. Here we see the clinical triggers, biomarkers, restrictive versus permissive guideline, and non-antibiotic intervention. These are important. And protecting the pipeline, that is the last one. So go to the next one. So first are clinical triggers. We all know these are very common points which we follow in ICU. Time-based review, biomarker guidance, microbiological results, clinical improvement, and alternative diagnosis if you can make, that is the non-infectious causes which is creating problems. So next one, please. So first one is restrictive versus permissive use of antibiotic. So this is a very important thing, and a very recent article which was published in 2025 in Biologics, they demonstrated that restrictive use reduced risk of acute kidney injury, the infection of Clostridioides difficile, and multi-drug resistant emergence, and microbiota dysbiosis. So all these things in combine has helped a lot as far as survival is concerned. And another data from United States says that there is a lot of misuse of broad spectrum antibiotic, almost 93 to 94% of patients, and they got a bad test out of it. And then they said tailored de-escalation via multidisciplinary protocol safely narrowed and covered almost 67% of pulmonary and 21% of abdominal cases. And then one more study, which is the randomized control trial, showed a shorter, from European Society of Intensive Care, shorter course of antibiotic is effective. So, and then in organ transplant patient, it also said that restrictive strategy has delayed the antibiotic initiation by 3 days and shortened the duration of antibiotic therapy by 5.8 days. So that is also a very important thing. Then non-antibiotic intervention, here we need multifaceted stewardship, and that achieves almost 15 to 25% reduction in broad spectrum antibiotic use, and that safeguards the efficacy of vulnerable population. And what is this multifaceted approach? You use multiplex PCR, MALDI-TOF, to get quick diagnosis. You use protocol, PCT guided protocols as shown in Adapt Sepsis trial. And you can use antibiotic sparing alternatives like phage therapy, that is also has come, and it has shown a very promising results, almost 87.5% of post-failure cases in cardiothoracic unit. And then SDD again has come back. One of the literature I could find in Journal of Critical Care that suggests that yes, it can be useful if we use it in a multifaceted manner. The last one is protecting the pipeline. And as of 2025, WHO reports that there is a decline in novel antibiotic from 97 candidates in 2023 to just 19. And only 15 of these are innovative agents. So it addresses a very critical priority pathogens like carbapenem resistant organisms, but the situation is not so good, and we have to really concentrate on this fact. And these are some of the reviews that says that antibiotic stewardship by a multidisciplinary adult and formulary restriction achieved 20 to 40% reduction in broad spectrum antibiotic, integrating rapid diagnostic. And then another important thing, if you use computer provider ordinary entry system as it is validated in one of the trial, INSPIRE trial, and that's in across 92 hospital, that slashed the ESBL by almost 27 to 35%. So finally, to conclude, a two-pronged strategy, precise therapy and stewardship, these are the two. But they obviously reduce the demand for existing antibiotic and boost the development of novel solution. But where we fit this infection prevention plan? So I will say it is not a two-pronged, it is a three-pronged strategy rather than two-pronged, where we can add not only infection prevention, but also vaccines and alternative therapies such as dual-acting immunoantibiotics. That is also very important, that effective treatment for future drug-resistant organism. So what we need at the end is a precise balance between these three, and that can provide a more comprehensive and sustainable defense against the global threat to antimicrobial resistance. Thank you.
Thank you, sir.
Sorry
I
for
think
taking
we have
this.
now come to the we have now completed the three scheduled talks. If there are any queries which the speakers had to answer, I think we can discuss them.
We don't have any question yet, Doctor.
Okay, thank you. There are no more questions. I thank all the three speakers for sparing time and sharing their expertise and experience on this. And we thank the World Federation for inviting the Indian Society of Critical Care Medicine and its leadership for this program. Thank you very much. Have a good day. Bye-bye.
Thank you. Thank you, everybody. Thanks.